There is a lot of timing concerns, a lot of hands in the cookie jar to make sure that all of this just goes perfectly and to make sure that that patient ultimately is able to get those cells.
Yep, you're right. Getting 3 matched donors for one person is like a miracle.
Fantastic. Yeah. These donors are amazing, and I think people don't realize that, number one, they're not paid, and number two, that they will often delay their own lives in order to be a donor. And these are complete strangers. They don't know who these people are, and so there really are a lot of amazing human beings in our world.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Joanne Kelly, Blood and Marrow Transplant Coordinator at SSM Health St. Louis University Hospital in Missouri, and member of the St. Louis ONS Chapter, to discuss what oncology nurses need to know about hematopoietic stem cell transplant donor selection and testing. Thanks for joining me today, Joanne.
Thank you. Thank you for having me.
So to start us off, can you please explain hematopoietic stem cell transplants and their role in cancer care?
Sure. So hematopoietic stem cell transplant is a treatment option for patients who have certain types of blood cancers or bone marrow cancers, such as leukemia, some lymphomas, or other immune system disorders. So when a patient has a dysfunctional or a damaged immune system, a hematopoietic stem cell transplant may be their only potential cure for their disease. So donors can actually donate healthy blood cells from their bloodstream or marrow in order to infuse that into the patient's bloodstream for the purposes of transplant. So essentially, a donor stem cells are used to replace the patient's damaged immune system so that they can actually get a new immune system from a donor that creates healthy blood cells and not cancerous blood cells.
Oh, thank you. So what are the different donor types that patients might receive?
For allogeneic transplants using a donor, there are different types of donors that can be used. So there's related donors, which would typically be a family member, like a sibling, child, or a parent. And then there are unrelated donors on the national registry called Be the Match, and that also includes umbilical cord blood units. So unrelated donors is someone who is not related to the patient, but could have a matching immune system with our patient. And we can search for those unrelated donors and cord blood units on the national registry. And currently, there are 19 million potential donors on the registry and over 249,000 cord blood units.
That's just amazing. Number one, that there's that many. And number two, that there are that many people that have stepped up and said that they're willing to be a donor if they would be a match.
Of course.
I mean, that's just an amazing thing. Quick question. So you mentioned Be the Match, and that is United States donors only, correct?
No, that's actually United States or international donors. So there are donor registries all over the world that all pool into the Be the Match registry so that transplant centers like ours can search for donors, for unrelated donors or cord blood units.
Thank you for clarifying that for us. Let's talk about the patients and how they would get referred to actually have a donor search or, started and taken place.
So when a patient is referred to our center with a diagnosis that may require a transplant using a donor, we typically see them in a consult appointment, and we do ask about their family members. So for example, how many siblings do they have? We do ask if they have any children and if their parents are still living, depending on their age. And then when we also, during their workup or evaluation, we draw some blood in order for us to match to a donor, and that blood test is called HLA typing.
Can you explain what HLA typing is and the purpose for it? And then what do you look for in those results?
HLA typing stands for human leukocyte antigen, and HLA is a protein or a marker that's found on most of the cells in our bodies. And our immune system uses these HLA markers to identify which cells belong in our body and which do not. So when we do HLA typing, we are looking at 10 HLA markers. And what we want is a 10 out of 10 HLA matched donor. The preferred ideal donor is a 10 out of 10 HLA matched sibling. So if the patient has siblings, we do a health history screening and then arrange for that HLA typing to be done if they are a good candidate. And then we use that testing to compare to see if they match. But unfortunately, siblings only have a 25% chance of matching that patient. So if the patient doesn't have any siblings or doesn't have any matched siblings, a 10 out of 10 matched unrelated donor is a suitable option. Sometimes a mismatched donor can be their only option. And this is when we might consider a half matched or a 5 out of 10 HLA match related donor. For example, that would be a child or a parent of the patient. So they would potentially be just a half match. We could also consider a mismatched unrelated donor from the registry or a cord blood unit, but that does come with risks of complications. It is considered maybe a higher risk transplant. So while we're looking at any sibling options, at the same time, we're looking at the Be the Match registry for any potential matched unrelated donors at the same time, so that we're not losing any time while we're waiting for the siblings to get tested.
The siblings get tested. You've got your Be the Match registry search started, and the results come back and the patient does not have a sibling match. So that means we need to go to an unrelated donor. What is the next step going to look like in identifying that donor?
So while we're testing siblings, we're also requesting some testing from these potential unrelated donors on the registry. So we usually put in a request through the Be the Match registry to have what's called confirmatory testing. So donors who've already joined the registry have already had their HLA testing done. And so that information is already in the registry, but we do have to confirm that those potential donors are indeed a match potentially to our patient. So those requests are going out at the same time that we're looking at any family members. And if it's determined that there are no family members that are suitable options or matches, then we just primarily rely on that, the national registry. So we do put in those requests to confirm those donor testings to see if they are, to confirm, if you will, that they are a 10 out of 10 match. And it can take several weeks to months to identify a donor. So once we have those confirmatory results on any, confirmed matched, really unrelated donors, we do want to select a primary donor and a backup donor. So we like to have multiple matched donors identified for our patients.
It's a tricky business.
It is.
I want to talk to you a little bit about the matches when you're looking for those. Can you talk a little bit about, first of all, let's talk about the patients, about how many transplant patients need to explore an unrelated donor?
Well, 78% of the patients don't have a fully matched related donor in their family. So the majority of the patients do need a donor who is unrelated, where we have to search on the registry. And the likelihood of finding a matched unrelated donor on the registry ranges from 29% to 79%. It really just does depend on the patient's ethnic background. For example, it can be more challenging to find a donor for African American patients, Hispanic patients, and Asian patients, as there's just not many donors from that ethnic background on the registry. So depending on a patient's ethnic background, it could really depend on the likelihood of finding a match on the registry.
Well, that's another interesting piece that gets thrown into the search process then, is looking at ethnic background. So now we're going to talk a little bit about the donors. What kind of complications might occur if a donor is not that 10 out of 10 perfect match for the patient?
Yeah, so if we have to pick a mismatched donor, a lot of times that is associated with a lower overall patient survival, higher non-relapse mortality, and higher GVHD. GVHD stands for graft versus host disease. And in this case, the graft is the donor and the host is the patient. So essentially what's happening is the donor graft, those donor stem cells don't recognize the patient. It doesn't recognize its home anymore. It's a different home. And so it really does try to attack that patient. However, sometimes there can be what's called graft versus leukemia or graft versus disease effect, and that can be a benefit to the patient, meaning that graft, that donor graft, is also attacking the patient's cancer cells, but it really can be a tough balancing act for the patient.
With my history being in transplant, GVHD is not a pleasant thing for patients to experience, and being able to do our best as the search coordinator to identify that perfect match or as close to perfect as you can get, it really is so important when you know what those side effects and outcomes might be, for those folks.
That's right.
So because of something, because of GVHD, and that we're not going to find a perfect match for everybody. So are there any of the allele matches that have more significance or mismatches that are maybe a lower risk for transplant recipients?
The HLA markers that we test for are called HLA-A, HLA-B, HLA-C, HLA-DRB1, HLA-DQB1. There's a stronger preference for HLA matching at the A, B, C, and DRB1 markers to lower that risk of graft versus host disease in the patient. A mismatch at the DQB1 may have less clinical significance. Therefore, usually transplant centers can consider a potential 8 out of 8 HLA matched donor, leaving out that DQB1. So those types of transplants are being done more often for those patients who don't have an 8 out of 8 HLA matched donor. Could be a really suitable option for those patients.
Definitely better than haplo, that's for sure. Just like with the new therapies that are coming along so quickly, I'm sure that advances have been made in HLA testing so that the donor selection can, be improved. Can you talk a little bit about what has happened over the last several years to improve that, or advances in testing?
Yeah, so our center is routinely looking at another HLA marker called DPB1. And we previously were not really looking at this or paying as close attention to it as we are now. And that's how we can search for a more defined donor match. So a DPB1 mismatch in a donor could be considered what we call permissive or non-permissive. So if that DPB1 mismatch is non-permissive, we know that that's associated with a higher risk of graft versus host disease, or host versus graft, meaning the patient may reject that graft. So we're looking at DPB1 more closely to just have like I mentioned, a better defined match. And on the registry, Be the Match is really trying to get that DP typing on donors who are joining the registry so that transplant centers like ours can actually see that information, and we can customize our donor list to have a more defined list of potentially matched donors that we would prefer be what we call DP permissive.
That's really interesting. I think, kind of like with genetics and genomics, as we're finding, where patients might have something that identifies them, to a certain marker, and, a treatment may work better and an immunotherapy may work better. The fact that we're able to, find the HLA alleles that may help patients to accept that transplant, or not have the risk of the GVHD that they have in the past, is just wonderful.
Right. And using that DP can actually just help, figure out, how are we going to treat this patient? What is the risk of GVHD, or is that risk higher? So knowing that we have a DP permissive donor over a non-permissive donor, it helps just essentially with their treatment overall after the transplant.
Yeah, that's wonderful. So let's say that you have identified 2 or 3 matched donors for a transplant recipient, which getting 3 matched donors for one person is like a miracle.
Fantastic. Yeah.
You kind of go into that, the meeting with everybody to talk about the patient, and the fact that you're coming with 3 recipient, potentials is huge.
Yes.
So now you've got these 3 that are matches. Then what's our next level? What would be the next thing that comes into play to determine what is going to be the best fit for that patient? Let's say you've got a female that is 50 years old and 3 children. Let's say you've got a male who's 42 and a male who is 25. What are you going to look at when you think about those?
Yeah, a lot of times we look at several characteristics between these donors, and sometimes it's really difficult to pick the best one if there are so many similar characteristics between those matched donors. At first we really try to focus on the younger donors when we even request that confirmatory testing on donors from the registry. So younger donors are preferred overall. We do essentially prefer a male donor for a male patient, or a female donor for a female patient, as long as that donor has no history of pregnancy. So when women have history of pregnancies, those are extra antibodies that are in their body that can sometimes just make it a little more complicated for the transplant recovery process. We also look at the donor weight, and sometimes we don't have that information up front from the registry when we, for example, if we're looking at a bunch of young donors, maybe we don't know how much they weigh. And you really want to have a donor that has a similar weight or a larger weight, higher weight than the patient, because the stem cell dose that we use to transplant our patient is based on the patient's weight. So if you have a tiny donor compared to a large adult patient, it could be really difficult for that donor to donate enough of those stem cells that we want for our patient. So we do get that information, if it's not already available, when that donor has the blood drawn for the confirmatory testing. We do get information like their weight. We also look at the donor's blood type and the CMV status, or cytomegalovirus. So if a patient has been exposed to the CMV virus, they have antibodies. In that case, we really would like to have a donor who also has been exposed to that virus at some point. However, if the only donor available is not CMV positive, that's okay. We just prefer that to match if at all possible. So when we have multiple donor matches, we're looking at several different characteristics, and sometimes we want to pick the best ones. We really like, again, young donors. We would love the blood type to match if possible, and we would like the CMV status to match, and then of course the weight. So if you have multiple donor matches, we like to pick our favorite one or our primary selected donor, and then to also have a backup option. If not 2, frankly, backup options would be ideal.
Thank you for explaining that. I can remember when I was doing searches, and we had a young man who was probably in his 20s, I think, something like that. And he had a Hispanic descent in his family. And so we were having a very difficult time finding a match for him. And the only match that we found for him was a woman, probably in her 50s, let's say, who had previous pregnancies. But that was the only match we had. And so you have to go with that. I mean, those are not the things that you want to see in the donor, and that wouldn't have been your best one. But the only other closest match was going to be kind of a haplo. And when you're looking at that risk, weighing that out, you really have to take all of that into consideration. So
yeah, you want to look at risk versus benefit, and if that really is your only donor option, you still want to transplant that patient. The risks don't outweigh the benefits of a transplant in general. And so you just treat the patient appropriately after the transplant occurs during the recovery period. And if that's your only donor option, the risk of not transplanting that patient would be higher than using a less ideal donor.
Okay, so now you've selected that donor out of your options there. What is the next step? Who do you contact to secure that donor? How is that process done? And what is done to protect the donor's anonymity?
So for two cases, actually, we could use either a related donor if we do end up having a related donor match. And our center, we coordinate those related donors. So we do ask them to come to our center for an evaluation where, number one, we want to make sure that it's safe for that donor to be a donor. And number two, to make sure that that donor doesn't have anything that could harm the patient. So for related donors, we coordinate their evaluation and donation at our center. If our primary donor is an unrelated donor, we request the donor workup and donation through the Be the Match registry. And so there are donor centers all over the world that coordinate the donor medical evaluation and donation. So depending on who the donor is, there are two types of donation procedures for either donor option. And one would be called a peripheral blood stem cell donation. And that is where a donor can actually donate the stem cells in their peripheral bloodstream through two IVs. And we can collect those stem cells and then get them to the recipient for the infusion. The other type of donation is a bone marrow harvest, which is a surgical donation done typically in the operating room, where we can actually go into the bone marrow space in the back of the hip bones or the iliac crest in order to get the stem cells directly from the bone marrow space. And then those cells can then also be infused into the patient for a transplant. As far as anonymity goes, for both related and unrelated donors, we really try to keep related donor information private as much as possible, even though they are a sibling or a parent or a child of our patient. We still want to keep their health information private. So while the patient may know certain things about their family member, we can't reveal most of it. We can only reveal to the patient what may affect them directly as a result of this transplant. But otherwise, we want to keep the rest of that information private for that related donor. For unrelated donors, the patient and the donor are actually assigned a special ID number so that real names or personal information is not being used. And transplant centers communicate to the Be the Match registry for this donor activity through a case manager. So us as a transplant center, we are not allowed to directly communicate with the donor centers. So it's always done through a case manager who will communicate back and forth between us to communicate our requests and their accommodations. So they take the confidentiality pretty seriously. In fact, our staff who work directly with donor activities for unrelated donors, we have to take confidentiality training so that we can maintain that anonymity for donors, but also for our patients. And we have to limit the information about the donor that's given to the patient. So we really don't reveal much information at all to our patient until we have that unrelated donor selected, that donor's been evaluated and cleared to be a donor. And at that point, we can tell our patients the donor's age, the sex of the donor, and the country that that donor lives in. There's no other personal information that's allowed to be communicated at that point. And vice versa. Typically, the donors are told really just the patient's age, the patient's sex, the diagnosis that they have, and they might be told the country that the patient lives in. So country only. They're not allowed to know specific states, specific cities, and things like that. So they cannot have direct contact with our donor for a certain period of time. So usually for those U.S. donor centers, donors who are in the U.S., they have to wait 1 year before they can exchange any personal information like name and phone number, address, etc. And that's if both parties agree to that. There has to be a consent form that's filled out in order for them to be able to release any personal information. There are some international donor registries that do require a 2-year waiting period, and some international registries don't allow any contact whatsoever. So anonymity, is maintaining that is very important. And so we do everything we can to make sure that limited information is given to the patient and the donor.
Yes, that's all really important. I think it's important on both sides. It's definitely important on both sides with that anonymity and then, waiting a year just with the difficulty of transplants and what patients go through. And, getting the cells is one thing, but that next hurdle, getting through the actual transplant and, out the other side is, can be a long road as well. So it is really important to be able to maintain that.
It is. And actually, sometimes, patients may need perhaps another transplant from that same donor, or they may need another type of cell called lymphocytes from the donor. So sometimes, we want to make sure that the donor feels safe, that they're not going to be bribed, right, or paid, like donors are not paid. So we just want to make sure that their privacy is maintained so that they don't feel like they are forced to do something. And that's why direct contact between patient and donor is just simply not allowed. But there may be additional requests of that donor if the patient needs other treatments down the line after the original transplant.
Exactly. So my next question brings us to this past year. Everything that we have gone through. And so, when we're thinking about how many people are on the registry and how important the registry is for these patients, how has COVID-19 changed the way that potential donors are, how they get in the registry, how they're tested and selected?
Yeah, so COVID, I think for everyone has been a thorn in our side, and it did create a lot of challenges, I think, for transplant centers that a lot of people don't really think about. So Be the Match donors in the United States, actually, they stopped doing blood draws for that confirmatory testing for transplant centers in order to cut down on the exposure, like person-to-person exposure, and it cut down on people going into labs and being exposed to other people and things like that. So they actually, Be the Match decided to stop doing blood draws, but they did do buccal swabs. So donors were sent a buccal swab kit to swab their cheek. And that's what was being used for the confirmatory testing. Most international countries were still allowing blood draws, but there were some countries overseas that actually stopped donor testing altogether because when we were in the peak of the COVID numbers, especially overseas, there were some countries that just decided to say, we're halting this altogether for a while. But it also created a challenge with getting courier flights arranged. So when a donor does donate, no matter where they donate, a courier is assigned to deliver that stem cell product to the transplant center. But scheduling flights was an issue since the airlines were dramatically decreasing their flights during COVID. There were all kinds of issues with courier itineraries and making sure that the stem cell product could get to that transplant center in a timely manner like before. There were just a lot of uncertainties with flight cancellations, COVID infection rates. Is this donor okay? Is the patient okay? So ultimately, Be the Match then required that all peripheral blood stem cell products, not bone marrow products, just the peripheral blood products, that they were to be cryopreserved or frozen when they arrived at the transplant center. And the reason for that is the donor was getting tested for COVID before they would donate. So that way we knew that donor did not have COVID, or hopefully. But then we were also testing the patient before they started that chemo prep regimen before their transplant. So the donor would donate, the transplant center would get those stem cells and freeze them, then make sure our patient is negative for COVID. Then we would start their chemo regimen before that transplant, and then we would infuse them. So we had to coordinate timing for all of this. We had to make sure the donor donated first, make sure our patient is still ready for transplant, and then, make sure that all the COVID is negative in both the donor and the patient before we proceeded with our patient. Because once that patient starts that chemo preparative regimen, they have to be rescued with those stem cells. So COVID really made things challenging in timing also, especially with the flights, like I mentioned, and then just COVID exposure. So what if the donor ended up getting exposed to COVID right before they were supposed to donate? that would definitely put a pause on our patient's plan. And we would either have to delay or perhaps work up and ask our backup donor to proceed. So we did have a lot of challenging situations in that in the last year just due to COVID.
It's such a precise process to get a donor, number one, like in normal circumstances. Then to throw that into the mix and, make sure that everything just happens, just on time, because, like you said, the patient can't start that preparative regimen and get to the point. And then the way we used to do it, you were flying to get the marrow the day before the transplant and getting back and walking from the airport right into the patient's room, and they were ready to go with that transplant. Where now, like you said, with the flight issues and just even how difficult it must have been with those international registries, because there were a lot of times that's where those donors came from, were from those international registries. It's not 100% from stateside on those registries. And so, to take that number of potential donors out of the mix, that could be hard. That could be really difficult for those folks.
Yeah, and in the beginning, when they actually stopped international travel, Be the Match had to really do a lot of work with local and international governments in order to allow couriers to even fly back and forth with these stem cell products. So it's not just as simple as saying, let's stop all international flights. We still have patients who need these stem cell products for transplant. And so COVID, just again, made that very challenging at the government level, federal level, the state level, all of that. And we had issues with some government rules overseas where we had to make sure that it was okay for that courier to even arrive to that country to pick up the stem cells. And there were also issues with some donors in some of those international countries who weren't allowed to travel to go to a center to donate. So we had, Be the Match, the case managers, they all had to work together to make sure we could get this donor in to donate, and then also to make sure we could receive those cells in a timely manner. You really want to infuse those cells within 48 hours if it is a fresh infusion, but we still want to be able to freeze those cells within 48 hours of the donation. So there is a lot of timing concerns, a lot of hands in the cookie jar to make sure that all of this just goes perfectly and to make sure that patient ultimately is able to get those cells.
Yep, you're right. A lot of work going into that, that's for sure. Now let's talk about oncology nurses. What are some key points that are critical for oncology nurses to understand about the donor selection process? Because these patients are probably going to encounter some oncology nurses before they ever get to the donor selection process or to that, step, or they might, see them first before, a coordinator gets to them and starts explaining things. So if that nurse is in that position, what are some things that are critical for them to know?
Well, when working with related donors, the primary physician or the nurse practitioner or even the coordinator that's caring for the patient really should not and cannot be the same team of physician and nurse practitioners that is evaluating the donor. So this really goes back again, partially to donor anonymity if it's a related donor. The same team may have a bias, right? Like they have a patient that they are caring for. They know that their patient needs a transplant. And here we have this amazing donor, this gracious donor who's willing to donate, but we really want to have an unbiased look at that donor. And actually that is a FACT standard, and FACT stands for the Foundation for the Accreditation of Cellular Therapy. And centers who are FACT accredited have to abide by these requirements. So having a different team of a physician or a nurse practitioner and including a coordinator really has to be a different team than who's caring for the patient. And again, it's really to determine, like I mentioned before, to make sure it is safe for that donor to be a donor. Is it safe for them? Are we going to put unnecessary harm to that patient? But then to make sure that a donor doesn't have any medical conditions or infections that could complicate the patient or cause that patient harm, for example, like an infectious disease like hepatitis HIV, or any other condition that could potentially harm the patient, that would be a greater risk to that patient.
Yeah, that is really important. Some really good points. So what is additional training or education that oncology nurses need to navigate, this aspect of cancer care?
Yeah, so the ONS, or Oncology Nursing Society, of course, has a good list of continuing education regarding stem cell and bone marrow transplants, including other podcasts that I've actually listened to myself and webinars. The Leukemia Lymphoma Society is also a really good resource for education for nurses. And then I would definitely recommend considering the oncology certification or the BMT certification for nurses who may want to specialize in oncology or BMT.
Great. All good suggestions on where they can get some of that additional information. And, like you mentioned with certification, for the BMT certification, ONCC does have, suggested resources that they can use to study for those exams too, which will also give them more education and learning for this area. So, Joanne, we've talked about a lot of different things with donors and selection today, and you have such a wealth of knowledge. But we're coming to the end of our time, and I have 3 questions that I kind of like to end all of my podcasts with. So I'm going to just kind of do a rapid fire at you here.
Okay.
With these. And the first one is, what are common misconceptions about hematopoietic stem cell transplants and donor selection?
There are many, and most often I hear from patients or even family members that we might want to test to be a potential donor. They think that certain medical conditions would prevent them from being able to donate. And that's not necessarily true. So, for example, I've heard, well, I have diabetes, I can't be a donor. Well, that's not necessarily true either. There's certain criteria that we follow to determine if someone is a suitable candidate for getting tested as a possible donor. Another example is certain cancers. You can still be a donor if you've had breast cancer, but never had chemotherapy or radiation. But we would still want to obviously evaluate that donor to make sure it's still safe for them and to really vet their medical history. So anyone that has several siblings, and if they say to me, oh, well, so-and-so is not in good health, I still want to talk to those siblings and family members to really get their medical history in order to determine if they really are a candidate. They may still be a candidate to get tested. It doesn't mean that they will necessarily end up donating. But we still want to talk to them because we wouldn't want to miss out on a potential donor option for someone who may have a misunderstanding of really what could be accepted as far as medical history. A lot of people also say, it's too painful for the donor, I can't do that. And then they're hesitant to learn more about it. But while the process of donating is not pain-free, it's something that can be managed. And I've worked with many related donors and unrelated donors because we used to do donor collections for the Be the Match registry for other transplant centers. So I've worked with both related and unrelated donors. And you really want to educate them and really fully inform them of what the process is of peripheral stem cell donation, bone marrow harvest. Right, it's not pain-free, but we can manage those symptoms. And for the most part, those pain symptoms that they do, the side effects that they do have are tolerable typically. And most donors I've worked with have actually said that it was not as bad as they thought it would be. So it's also important to validate their concerns, but to also educate them so that they're making an informed decision and to make sure that their pain or their discomfort can be managed well.
Great. What's something about this process that's not often discussed, but you wish people knew more about?
The biggest one that came to my mind was that donors are volunteers. These are volunteer, gracious donors who do not get paid. And a lot of times donors, when they are contacted as a possible match for someone and they go through the testing process and the health screening, and if they are the ones that are selected, I've heard stories of donors who have actually perhaps delayed starting a family because they want to make sure that they are ready and healthy and fully able to donate once the donation is to occur. So these donors are amazing. And I think people don't realize that, number one, they're not paid. And number two, that they will often delay their own lives in order to be a donor. And these are complete strangers. They don't know who these people are. And so there really are a lot of amazing human beings in our world. I will say, though, even though the volunteers are, these volunteer donors are not paid, they do get their medical care and their donation covered. And that's typically covered by the recipient or the patient's insurance. Another thing that I briefly mentioned before is that we cannot force these donors to donate. If this is something that is just not in their best interest, there are complicated family dynamics that I've seen. There's extreme fear and anxiety in donors that I've seen. And sometimes we have to defer a donor for those types of reasons, or perhaps we have to defer a donor for a medical reason. But either way, that brings in their anonymity. That is their personal business, and we cannot inform the patient any kind of further information as to why a donor cannot donate. It could be a medical condition, it could be a personal issue. So we also cannot force them, bribe them, manipulate them, make them feel guilty. We cannot do that. So our center in particular, we really do not judge these patients if for any reason they cannot donate. We have to respect them as human beings. We have to respect their decision, whether it be for medical reasons or personal reasons.
Okay. And last, what are resources for clinicians, patients, and caregivers who want to learn more about the whole donor process, HLA testing, serving as a donor? What would you tell them?
We refer just about everybody to the Be the Match website, and that's a website where people can learn about all of those things. There's a section about transplant basics. There's a section about how to be a donor if you want to join the registry, and there's also a section for caregivers. Caregivers have a really big part in the transplant process. A patient really needs to have a caregiver 24 hours a day, 7 days a week for several months for these patients. And so the Be the Match registry is a really great resource for clinicians, patients, caregivers, and anyone who actually might be interested in joining the registry.
Well, Joanne, thank you so much for joining me today. Again, you have just given us a wealth of information, and it's definitely an area that's fun for me to talk about because I loved being a search coordinator. It's so challenging in trying to identify, a donor for somebody, but it's so amazingly rewarding when you do find that one match and you see that whole process come together. So do you have any final comments for us today?
I don't. I just thank you so much for having me. And like you, I actually love what I do. I have a pretty amazing job.
Well, thanks again. It was a real pleasure having you on with me today.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.